And our last speaker, but not least today, is Paul Thomas, who's a scientific consultant with the office also. And he works primarily preparing the dietary supplement fact sheets along with other educational materials and does a lot of interaction with the media. And Dr. Thomas also manages the Federal Working Group on Dietary Supplements, so that's our federal partners that have interests in this area. And it serves as a means of communication between ODS and the federal partners to co-fund research and expand opportunities in terms of research, investigator training, and strengthen collaborations throughout. So please welcome Dr. Thomas.
Thank you. Good morning. I'm going to give you a few examples of research on supplements for the different reasons that people take supplements. Research that's good, not as good, and simply what we've got to date. And I'll conclude with some lessons that I take away at least from this practicum as we study supplements, as we use them ourselves, and as we recommend them to others. So Dr. Dwyer told you earlier about why people take supplements, and there are three broad reasons, I think. First, what some might call nutritional insurance. You don't eat as well as you should all the time, and you think you may not be getting recommended amounts of all the nutrients. And then there are certain groups that are advised to get nutrients from either dietary supplements or fortified foods, like folic acid before and during pregnancy, and people over 50 for B12. And then some people supplement because they hope for some kind of benefit in a general way, just kind of to feel better than they do, or to have their body work better, like an immune system that might help prevent colds and flu. And down the line, over use for many years and decades, maybe to be more resistant to diseases like cancer and arthritis. And then some people supplement for very specific targeted purposes. An athlete might take an ergogenic aid to enhance performance, maybe just for stronger nails, fingernails. And people take supplements to manage their diseases and health problems, of course. Now, supplements, of course, can't be promoted for disease prevention or treatment, but people can take them, and health professionals can recommend them for these purposes. Now, Dr. Reagan Bailey's research shows us that people take supplements mainly to improve or maintain their health. You've heard this from several speakers. They want results. They're not taking them nearly as much just to supplement their diets. And I'll give you research examples for each of these three broad reasons. So let me start with the multi again, but I'm going to go somewhere different with this. A supplement of only or mainly vitamins and minerals. They're the most common supplements used in the United States, have you heard, by far, and some 1/3 of all Americans take multis. And they account for about 1 out of every $6 spent on supplements, or over $6 billion a year. Now, the multi is arguably the product to supplement the diet for nutritional insurance, an easy and inexpensive way to meet or even exceed recommended nutrient intakes, right? But there's no standard or regulatory definition for a multi, like what nutrients it has to have and at what levels, or if it might include other ingredients like herbs. Companies choose the types and amounts of the ingredients in their products, so the result is that there are hundreds of multis in the market, none of them completely alike. Many claim to be complete and balanced, which you would want for nutritional insurance, but are they? So here's a nutrient breakdown of 2 of the best-selling all-in-one multis for senior men 50 and older. Now this chart is hard to read, but just focus for a second on the colors. The nutrients in blue have the greatest differences in amounts between the 2 products, of 100% or more of the daily value. Now in yellow is where the nutrients are pretty high, more than 150% of the DV, and green is where the nutrients are much lower, less than 50% of the DV. And DVs, of course, are simplified versions of the RDAs and AIs. So this is easier to read, just the nutrients with the colors. So these two top-selling multis are quite different from each other. For example, one is 3 times higher in vitamin K, but the other is 3 times higher in chromium and thiamine. And all that yellow. 3 times the DV for B6, more than 4 to 16 times the DV for B12, more than twice the DV for manganese, of all things. Selenium above 150% of the DV in one, but below 50% in the other. And then there's the green, where the nutrients are low, mostly calcium, magnesium, and especially potassium, where the amounts needed, in hundreds or thousands of milligrams are high. Adding the DV of these nutrients would make the pill too large to swallow, of course. Now, some multis come as daily packets of several pills. Their advantage is mainly that they provide more calcium and magnesium, but almost all multis, even in the packs, are very low in magnesium, in potassium. My point is that taking a multi for nutritional insurance is like buying a policy full of coverage gaps and excessive add-ons. And that's the case for multis for seniors, younger men and women, and even kids. Well, so what might a better one look like? Well, one option might be to include nutrients at consistent fractions of the DV, say 25% for people who eat really well, and 75% for really poor eaters. And then why do multis provide so many nutrients at or above the DV if it's meant to be a supplement and not a substitute? Even a terrible diet provides some vitamins and minerals. And another option would be for the multis to emphasize more the nutrients of concern in the American diet, as noted in the latest dietary guidelines for Americans. Vitamins A, C, D, E, K, calcium, magnesium, potassium, choline, which isn't even in any of my 2 examples, and not be so overgenerous with most of the B vitamins, and include more potassium, which will be one of the 4 nutrients required on the new food and supplement labels next year, that is if they're not delayed. Well, anyway, beyond nutritional adequacy, supplements are also used in the hopes of reducing chronic disease risk over time, including the multi. And you heard about the Physician's Health Study 2 yesterday from Dr. Sesso. It examined whether taking a multi could keep subjects healthier for longer. It really was an elegant study, and it had quite a simple design. Starting in 1997, almost 15,000 male doctors across the US were randomized to take either a daily Centrum Silver or a placebo for about 11 years. They were middle-aged or older and mostly white. And Centrum is the best-selling multi on the market. Now, to prevent heart disease, the multi was of no value, and it didn't matter whether the subjects had any history of heart disease or what their baseline nutritional status was. Also, the multi didn't slow down or prevent cognitive decline, and it didn't prevent age-related macular degeneration of the eyes either. But the results were better for cancer. Men taking the Centrum had a lower risk of cancer. It was about 8% less, and given a hazard ratio of 0.92. And the researchers called this apparent benefit modest. That's their word. And yet there were no differences between the groups for site-specific cancers, like the prostate or the colon, and cancer mortality was the same in both groups. And the multi also modestly reduced cataracts. Of the 1,800 cases that developed, there were 73 fewer in the men taking the Centrum compared to the placebo. Now, one good thing the investigators did was to use a version of Centrum Silver that stayed exactly the same over the 11 years. The dozens of ingredients and their amounts didn't change over time, as they do for multis in the marketplace. Today's Centrum Silver, for example, has more vitamin D, has less A, more of the A is in the form of beta-carotene than retinol, and it has the added carotenoids lutein and xanthine. And whether these changes would affect the results of this study really is anyone's guess. And of course, we don't know whether these results apply to women or to people who take a multi at earlier ages or for a longer time. And would the results even apply to a more diverse group of middle-aged men that aren't as well off as doctors and might not take as good care of themselves? And since most subjects were white Caucasians, would they even apply to other racial and ethnic groups? So on the basis of this study, would you take or recommend a multi hoping that it might increase a healthy lifespan? Well, given the modest benefits, there are clearly more important things you can do to reduce your risk of cancer and cataracts. And when the U.S. Preventive Services Task Force looked at all the studies in multis and disease risk, they concluded that the evidence is insufficient to determine the balance of benefits and harms for the prevention of cardiovascular disease or cancer. And they, of course, called for further research. We always do that. One bottom line is that when you read a study on multis, you need to know how they were defined. Many speakers have mentioned that. Or in doing your own research on them, choose an option or define them yourself. And know what supplement products would be included or excluded by your arbitrary definition. So let me discuss another clinical trial with ingredients found in supplements, this time for disease treatment, and specifically for age-related macular degeneration. It's a leading cause of blindness in the elderly. And over time, blind spots develop in your center of vision, and your vision gets blurry. Now, these two are elegant trials, but they have a much more complicated setup. In the first study, known as the Age-Related Eye Disease study, or AREDS, 3,640 adults, 55 to 80, with some AMD or evidence of developing it, were randomized in 4 groups. One group took a daily antioxidant combo of 500 milligrams of vitamin C, 400 IUs of E, and 15 milligrams of beta-carotene. Another took a high dose of zinc, 80 milligrams, and because that was so high, some copper to balance it. And that's because an earlier small study found that high doses of zinc might help vision. That's why they included it. A third group took the antioxidants plus the zinc and the copper, and the fourth group got the placebo. Now, obviously, this was a disease treatment study, but it has a prevention aspect too, maybe slowing the progression of early or intermediate AMD to its more advanced forms. It turned out that those who took all the 5 ingredients benefited the most. Using the combination every day over 5 years cut the risk of those with intermediate AMD getting advanced AMD by 25%. Alas, the supplements didn't reduce progression from early to intermediate AMD. Now, after this study, all the interested subjects were allowed to take the full combo, and they were followed for an additional 5 years. And again, the risk of progressing from intermediate to advanced AMD was reduced by 27%. Now, by the way, I doubt anyone would call this antioxidant combo a multi. It's certainly not used for nutrition adequacy, but by some definitions it is. It has 5 vitamins and minerals and no herbs. Well, then there was AREDS 2. The AREDS 1 formula was tweaked to see if it might help more people. First, they removed the beta-carotene, since 2 earlier trials showed that high doses increased the risk of lung cancer in smokers. And it was replaced with 2 other carotenoids, lutein and zeaxanthin, which are actually found in the macula of the eye, while beta-carotene isn't. There's a lot of these carotenoids in green leafy vegetables, and AREDS 1 found a relation between eating these foods and a lower risk of AMD. Now, also, they reduced the amount of zinc. In AREDS 1, those who took the high zinc dose, they were hospitalized more often for urinary tract infections. Also, the men developed an enlarged prostate more often, and women were more likely to get stress incontinence. That's like leaking urine when you cough or you laugh. And then they added the fatty acids EPA and DHA. In AREDS 1, subjects who ate fish just 2 times a week had a lower risk of intermediate and advanced AMD. So can we bottle that? So in 2006, AREDS 2 began. It had 4,200 subjects with intermediate AMD in both eyes, or intermediate in one and advanced in the other. And they were the same age range as in AREDS 1, 50 to 85, and they were treated at 82 clinical centers across the United States. The subjects were randomized into 4 groups. Now, one took the AREDS formula with the zinc and the beta-carotene, which was now serving as the control. Another group took Eretz with 10 milligrams of lutein and 2 of zeaxanthin, and a third group took Eretz with 1 gram of DHA and EPA, and a fourth group just took it all. Now here's where it gets complicated, because in these groups, subjects were also randomized so that the Eretz formula had some had the beta carotene removed, including in all the smokers. And in others, the zinc was reduced from 80 to 25 milligrams. Now the main findings were that the lutein and zeaxanthin and omega-3s gave no added benefit to the basic Eretz formula. They didn't further reduce AMD progression, but there were lots of subgroup analyses and results, and here's just a few of them, the gist. While the original Eretz formula can significantly slow the progression from intermediate to advanced AMD, a formula with no beta-carotene and only 25 milligrams of zinc works fine. And substituting lutein and zeaxanthin for the beta-carotene seems to improve the formula, but only in those people who don't get much of these carotenoids from food. And there was one important caution. It was the former smokers who took the Eretz formula with beta-carotene had twice the amount of lung cancer compared to those taking the formula without it. So it's not just current smokers who are at risk. So the Eretz studies really are a great example of where good science, including evidence of efficacy and safety, can and should be used to drive clinical practice. And 2 years ago, the American Academy of Ophthalmology told its members to consider using the Eretz formulas to treat patients with intermediate or advanced AMD, but they weren't appropriate for those with early AMD. But the reality here is that for many supplement ingredients or combinations, there's either no good research, or what's available is really just a jumble of studies of variable quality, no consistent bottom line of value or safety, and no reputable expert body would weigh in or give the therapy a thumbs up. So let me give you 2 examples. This is the B vitamin biotin. It's an ingredient in supplements that are touted for improving nails, hair, and skin. Our office was asked about biotin's value in strengthening nails a couple of months ago, so we looked at the published research. What it amounts to are 3 small studies, with 1 in German, with only an abstract in English. A total of 102 patients with brittle, splitting, or soft nails. They were treated for 5 to 15 months with a very high dose of biotin, 2.5 milligrams per day, or more than 8 times the current daily value. And the supplement appears to improve nail hardness and thickness in a majority of this small group of patients, but not in others. And the studies can't tell us who might or might not benefit. And my other example is sodium bicarbonate, baking soda. It's actually available as a dietary supplement, and it's taken by some athletes to improve their performance. Now, this is a supplement that literally has been studied for about 80 years. And there are dozens of studies in swimmers, in cyclists, in rugby players, and the like. But most of the studies include only a dozen or so subjects. They're tested in a lab over several days in rather artificial conditions. And they show that people have different responses to the bicarbonate loading. Some seem to improve their performance in strenuous exercise over several minutes, or in sports that have intermittent levels of intense, high-intensity activity. And then there are others who get no benefit. And in some, the supplement actually hinders their performance. And in any given individual, the supplement can help at one time, but not in another. And despite all this work, we don't know why. We're not even sure about how bicarbonate might help performance. The current thought is that it reduces a metabolic acidosis from lactic acid buildup that makes you feel tired. So what to do in both these cases? I can understand those who might say not to bother with the supplements because the research support is weak or not conclusive. But I can also understand those who think it's worth experimenting to see if the supplement works for them. especially if there seems to be little or no risk of side effects. Biotin, for example, seems quite safe in even high doses, and no upper safety level has been set. And so that's the case with using many supplements for reasons that go beyond nutritional insurance. A little information or conflicting information about possible benefits, and virtually none of the studies are powered enough to uncover potential harms. So depending on our attitudes about supplements, our ideology, our worldview, as a user or as a practitioner, we're likely to pretty much avoid them or to see them as complementary or integrative approaches to address health matters. Now, you've learned that there are all sorts of challenges and considerations in researching dietary supplements, and that's just for the hundreds, if not thousands, of single ingredients, the bulk of the science. The challenges multiply for ingredient combinations. And the products being brought to market are increasingly combinations of ingredients touted for specific purposes. They're called, again, specific condition-specific supplements for reasons like heart and bone health and blood sugar control or weight loss. And they fit into why a majority of people say they take supplements to improve or to maintain their health. And now take joint health, for example, a category with more than $1.6 billion a year in sales. And on the right of this slide, I've listed just a small number of the ingredients that might be found in them. Each company's entries have a different mix of ingredients and amounts. You know, the thinking behind many of these products seems to be to combine ingredients that have even the tiniest bit of science behind them a benefit in the hope that one or more of the ingredients in them might help the user. Or even better, maybe there's some ingredient synergy. But without any research support of the combination, of course you can't know. And just maybe the combination might not work as well as single ingredients, or that any synergy might actually work in the other direction, of no benefit or increasing the risk of harm. The user becomes the research subject. Now, the focus on condition-specific supplements and with both single and combination ingredients is evident on both company websites and in the physical stores. You can search online for the body part or the system you want to fix or maintain, or for a problem area, for your liver, for your urinary system, or for something like pain or insomnia relief. There are sections in stores for supplements for cleaning and detoxification, for heart health, for healthy aging. I like to tell the story of when I was working in health food stores in the 1970s, the supplements were organized in alphabetical order, you know, vitamin A to K, the minerals, you know, all the way down to zinc and herbs alphabetically. That is no longer the case in the marketplace. Now, obviously, we need more, or in many cases, really just some research on these products to evaluate their value and their safety as more people use them. But their number and composition in the market grows so much faster than the pace of our science. The industry refers to this as product innovation and the need to be innovative. So we, as investigators, probably need to talk more about the kinds of research we need and which supplement ingredients and combinations to study. So let me wind down here. Over the 3 days of this practicum, you've learned a lot about dietary supplement efficacy, safety, and quality, and oversight and regulation of the industry. And as I've listened to these talks this time and in previous practicums, these are some of the lessons that I take with me about choosing and using supplements. The first is to choose the right dose and timing regimen. Often we have reasonable science to guide us, like the doses of glucosamine and chondroitin, most often used for treating osteoarthritis, are 1,500 and 1,200 milligrams per day, respectively, but taken as 2 or 3 doses separated by several hours, not all at once. For St. John's wort to treat mild to moderate depression, the usual dose is 900 milligrams per day, taken in 3 equal doses spaced out of 300 milligrams. And for maximum absorption, keep your calcium intake at any one time to under 500 milligrams. Second, consider the supplement form. And for some ingredients, this is important. Again, with calcium, calcium carbonate is best absorbed with meals, but calcium citrate can be taken any time. For chondroitin, which is a carbohydrate polymer, one of low molecular weight might be best absorbed. And often we don't really know. With echinacea, for example, you have your choice of 3 different species, angustifolia, pallida, and purpurea, and 4 different plant parts, the roots, the stems, the leaves, and the flowers, and then combinations of species and parts in all different kinds of echinacea supplements. Which is best? You can't really know, but for what it's worth, Consumer Lab advises that the aerial parts, the stems, the leaves, and the flowers of purpurea. So if you're going to try it, maybe that's the one to try first. A third consideration is really mainly for botanicals. It's often best to choose a product whose composition is standardized, like the ones typically used in clinical trials. Many studies of ginkgo, for example, they use an extract standardized to 24% flavanol glycosides and 6% terpene lactones. And for saw palmetto, a product with 70 to 95% free fatty acids. And fourth, in some cases, a supplement from a specific company might be good to try first. And that's because the company has actually studied the product, or the amount, the form, and the standardization of its ingredients actually conform to those used in studies. Now, we don't usually plug specific products, but sometimes one brand has more science behind it than another. And here are some other takeaways. If you take a supplement for some purpose and it doesn't seem to be working, before you give up on it, try a different brand, a different form, a different mix, a different something. The reason might be a quality problem with that product. Maybe another one, processed and manufactured differently, with different excipients, a different chemical matrix, might be more effective. In general, I think avoid products with proprietary blends. If you don't know the exact amount of each of the ingredients in the product, you can't know whether they're present in meaningful amounts. And of course, the instructions for use on a label is either often not very helpful or is really wrong for what you're using the product for. And every time you buy a new bottle of a product you're taking, check the supplement facts panel. Products, especially with multiple ingredients, change over time. Be sure it's still something that you want to use. And some buying advice that makes some sense to me. First, maybe buy from companies that are large enough to have a national presence. They're likely to pay more attention to quality issues in supplement manufacture because they have more resources to do so and more to lose if their reputation is questioned. And maybe buy from companies that are members of supplement trade associations like CRN and APA. They have codes of conduct and expectations for the development, manufacture, and marketing of a member's products and ingredients. And then maybe buy products that have been evaluated by a responsible third party, like the USP and NSF, which evaluate not only products, but a company's manufacturing and quality assurance facilities, or ConsumerLab.com, which tests products that are already being sold, but they don't test company facilities. Companies and products that pass are listed on their websites, and the products may even have a third-party logo on their labels. And then finally, I'd also make use of the ODS Dietary Supplement Label Database to learn the choices you have available for any type of supplement. By doing this, it's really easier to find exactly what it is you're looking for. My gosh, and with plenty of time left, I'm done, so I will try to answer your questions. I know you want to get out of here. But also, let me ask you, what are the most important takeaways that you've learned here about studying, choosing, and using dietary supplements and about their oversight and regulation? So, thank you. Any questions I can try? Yes.
On one of your slides, you talked about sodium bicarbonate, and but one of the things that has not been addressed at this weekend or this week was the thought today about alkalizing your body, and that sodium bicarbonate was something to be used every day in order to do that. Are there any thoughts on that?
No, I mean, that is the current rationale for how it might be effective, that it would reduce or counter the lactic acid buildup that ultimately leads to fatigue, or one of the reasons why you get fatigued when you're doing high-intensity activities. It's not exactly clear that that's the case, and again, we don't understand why it happens in some people and not others, even when their pH actually, goes up a little bit, or why it works some of the time and not others. Again, 80 years of research, lots and lots of small studies. One of the things about the sodium bicarbonate, it's really very interesting because the dose that one of the things they've kind of keyed in on is the actual dose of the sodium bicarbonate to use. And that is about 3 to 5 teaspoons of baking soda. Now think of this, that is incredibly salty, and it is pretty much inedible by itself and even in water. So it's put in a number of different kinds of drinks where you're obviously trying to mask this. It leads to water retention in a fair number of people. It leads to a bit of nausea, upset stomach, in some cases vomiting, and so on. Again, it occurs some of the time and not in others. But if you're looking for a performance advantage, it is one of the supplements that a fair number of athletes are trying, particularly in, say, competitive athletics, not necessarily for the weekend warrior, but when your time, maybe a second or a fraction of a second in some kind of race or event might make some sort of a difference. Are you willing to try that and risk the potential side effects, or see if it works for you that one time for that one race when it might not have the other time?
As a follow-up, there's another thing that seems to be hitting the marketplace, is that to do this for, say, illness prevention, like cancer and things like that. Any thoughts on that?
No, I don't. And we, as an office, don't really get into the use of dietary supplements on the whole for actual disease treatment, but mainly in its prevention. Just with the sodium bicarbonate example, in addition to a dietary supplements fact sheet on weight loss, we have one on exercise and sports supplements that will probably be done and out, I would hope, by sometime next month. And it's going to be large and extensive as the one we have on weight loss and includes sodium bicarbonate. Yes, Johanna?
Just to continue on the bicarb, I think Paul and I, for our sins, have been reviewing a lot of articles for a supplement for an unnamed journal. And several of them have been on beetroot juice. And some of them are interesting, but inconclusive. Beetroot juice apparently has a lot of bicarbonate. And some of the clinical pharmacists and physicians in the audience, if you do a lot of work with renal patients, there's a great deal of interest in bicarb and the whole issue of acid-base balance with them. And also I know Bestos and Hughes at Tufts, who's done a lot of work on bone, they're very much interested in using food sources of bicarb. Well, it's not bicarb, but it's basically affecting acid-base balance. I think prunes and some other things like that.
It's basically kind of the Mediterranean diet that is overall more alkalizing because of the selection of the foods than a standard, meat, potatoes type of a diet. The other thing about beetroot, which we also look at in our upcoming performance fact sheet, is that beetroot juice is also a very high source of nitrate. for endothelial function and expanding the arteries a little bit, and maybe promoting a little bit more oxygenation to the tissues. Some interesting science there, some decent science, and overall, it's still a little bit iffy. It's sort of in that area where you can't really say definitively, you can't really say whether or not it's going to work for you. In the end, it amounts to, you know, what's your worldview? What's your attitude towards supplements? What's your need for a performance enhancement? And are you willing to try this, and for how long, and at what dose, and for what activity? Yes?
Thank you very much for your presentation. I think I'm about to ask a rhetorical question. Given what we've learned so much about the lack of evidence and the need to do more research, I'm wondering if you see the office's role as serving as a repository, for lack of a better name, of endorsements or clinical practice guidelines. So I appreciated the example today that you used with macular degeneration in the American Academy of Ophthalmology's statement based on current best evidence. So I'm wondering, do we see this evolving as a place where we can see a state of the science?
How about, let me ask you to save that question, or we will answer it when our little panel comes up, because that I want to have other people involved in trying to answer. Are there any more specific questions about my presentation before we move to the panel?